Hi everyone, this is Otieku. I'm glad to be part of this year's conference to share my work on cost effectiveness of surgical site infection intervention in Ghana. This is a work by myself, Otieku, a PhD student at Aarhus University in Denmark, and by Ama Pukia Feni, also a senior research fellow at the University of Ghana, Felix Ankuma Asante, University of Ghana, Antoinette Bediakubowan, University of Ghana Medical School and Kolebu Teaching Hospital, and Eureka in Denmark of Department of Public Health in Aarhus University in Denmark. Our presentation today form part of a bigger project ongoing in Ghana, which is dubbed High Ghana Study, and High simply means Healthcare Associated Infection Study. The overall aim of High Ghana Study is to measure the direct, indirect, and opportunity cost of highs in Ghana, and specifically to estimate the direct and indirect cost associated with surgical site infections, and to do same for neonatal sepsis, and same for puerperal sepsis, and also to estimate the social cost of healthcare associated infections generally for Ghana, and by so doing to also evaluate the cost effectiveness of control interventions associated with selected highs. The premise of my presentation today is that the risks and cost of surgical site infection in high and low middle income countries is high, and that decision makers require empirical proof to invest in SSI interventions, but limited published information exists in the context of Africa, including Ghana. And so the aim is to assess the cost effectiveness of SSI surveillance feedback mechanism at a referral teaching hospital in Ghana. And the hospital in question is the Kolebu Teaching Hospital, which is a public health facility that has a 2,000 bed capacity. And patients are treated upon referral, and only when they arrive and their cases require emergency medical attention. Our study sought to answer one research question, which is that is an active 30-day SSI surveillance cost effective compared to a no surveillance practice? Over the years, the hospital or Ghana as a whole, we've had a no SSI surveillance system to monitor outbreaks of SSI, and also to make data available for cost estimates to understand the economic burden of SSI. And so this study, which is part of the High Ghana study, seeks to evaluate the cost effectiveness of a 30-day SSI surveillance intervention as compared to a no surveillance intervention. In doing so, 5 outcome measures were pursued. The first is the SSI mobility risks avoided with the intervention. That is whether or not the intervention will lead to SSI mobility risks avoided or reduction, and also to assess the incremental length of hospital stay due to SSIs, and the incremental outpatient visits due to SSI, the incremental laboratory test due to SSI, and the incremental cost avoided with the intervention. In my next slide, I shared the methods used. For methodological accuracy, we adopted the Consolidated Health Economic Evaluation Standard, which is the CHES checklist. By way of design, the study was a pre and post intervention. The pre-intervention took place between June and September 2017, while the post-intervention took place between April and July 2018. The lag time between the two studies was to make way for the intervention to go on for a while, and also to use the pre-intervention study outcome also to educate staff to raise awareness about the incidents in the hospital. And while the intervention was ongoing, In April, we ruled out the post-intervention study to also capture the costs of SSIs and also evaluate the incidence. And so patients and carers of patients identified as having SSI in both the pre and post-intervention were administered a validated structured questionnaire to capture the direct and indirect costs associated with SSI. All costs were calculated in Ghana cedis and converted into 2017 purchasing power parity using a recommended web-based PPP converter. In my next slide, I share the descriptive statistics of our results. Now, in the first row, you see the CES. Okay, so you can see here it is captured as CES of neonates, which is because we also did similar study for neonatal sepsis. And so this is a CES of SSI. The males, in the overall study, a total of 446 eligible patients were enrolled in the study, of which the SSI incidence, of which 62 SSI cases were identified actually, but only 40 were included in the analysis. And the reason being that some were lost to follow up, while others we could not match them because in both studies we did a control study, as in a cohort study, where we compared the cost between the case group and then the control groups. But for the case group, there were 62, but for the cost analysis, only 40 were included for the reasons mentioned. And in the post-intervention also, only 31 were included in the cost analysis for similar reasons. By way of gender, I said, in the pre-intervention, the males were 22% in the case group, and in the post-intervention, the males were 38.8% in the case group. So what you see here basically includes the matching criteria used in both the pre and post-intervention studies. It also includes the ASA, which is not shown but was included, the wound class, whether or not the wound of the SSI was clean, whether it was clean contaminated, and whether it was contaminated or dirty. And then we also look at 11 surgical procedures. We see that for the cases that were compared, we see that in the pre-intervention group, the majority of cases were those who underwent herniorrhaphy, which is hernia surgery, 27.5%. And I think the least is 2.5%, that is those who underwent rectal surgery. And then when you come to the post-intervention, we see here that the majority were those who underwent breast surgery, which is 22.6%. And the least were actually those who underwent small bowel surgery, which is 3.1%. In both cases, we also did a non-parametric test, just so we are sure that our comparisons are not statistically different in terms of background characteristics. And so here in the last column, we see we have calculated the p-values for our comparisons. Yes. In my next slide, I project the incremental outcomes between the pre and post intervention. The variables of interest here are the total mortalities recorded in the overall sample. Was in the pre-intervention, it was 7. And for the post-intervention, 2 cases, 2 mortality cases were recorded. And so with the intervention, we observe a 71.4% morbidity risks avoided. And in terms of the mortality risks, which is actually, this is actually for the case group for the SSIs. This is for the first one I mentioned was for the overall sample. And for the case group, which is among the SSIs, we observe a 33.3% decline in SSI mortality rates. And for the mean additional LOS for SSI patients, we also observe a 32.6% decline. And for the mean number of outpatient visits for SSI patients, we observe a 34.2% decline. And for the mean number of wound swab, which is a laboratory test to confirm the SSIs, we also observe a 48% decline with the intervention. In this slide, table 3, I project the incremental cost of SSIs. And so we see that for the key takeaway here is that the mean patient total cohort cost, which is the combination of the direct and indirect cost. And here the indirect cost is actually the productivity loss. That was, we took into consideration absenteeism from work. And so we were able to calculate the cost of productivity loss to be on average among the pre-intervention group, $625. And for the post-intervention group, it was $547. What you see in the bracket are the 95% confidence intervals. And so we have a 12%, 12.5% decline in productivity loss with the intervention. And for non-medical costs, which actually includes the cost of transportation and feeding outside the hospital while the patient is on admission. I mean, sometimes, although the hospital provide meals, not in all cases that patients feel that they want to eat the meal provided by the hospital, and so they have appetite for food prepared outside, which they have to buy at additional cost. And so we captured all that as a non-medical cost and evaluated same. And so we observed a 23.4% decline in those costs to patients of SSIs. And the costs that were evaluated from the provider perspective, which is the hospital cost attributable to SSI, overall in the pre-intervention group, it summed up to $1,495. And with the post-intervention, it summed up to $1,209. That resulted in a 19.1% decline, also with the intervention. In my next slide, I project the incremental cost effectiveness ratio. We see that the total costs of the intervention with the intervention was $102,000, $102,263 as compared to $147,126. That led to a reduction of $44,863. And in terms of the total number of SSI patients avoided, we recorded 13 cases avoided because with the post-intervention, we observed 49 cases of SSI as compared to 62 cases in the pre-intervention. So all this resulted in an ISSER of 3,451 in cost US dollars in cost savings per SSI cases avoided. Now that is by dividing the difference between the total cost of the pre-intervention and post-intervention, dividing that by the effect gain, which is 13, and so you arrive at this. Now we, in trying to generalize the finding, we also extended our analysis to cover the whole of Ghana, And we realized that a total of 869 surgeries are performed across the country per 100,000 of the population. And that results in 260,700 surgeries in 2020 alone. Now, assuming SSI rates of 11% as observed in the surveillance study, the surveillance study is actually a published study in the Journal of Hospital Infection, and the pre-intervention study is also published in the Journal of Infection Prevention in Practice, which is an Elsevier journal, all published in 2020. You have most of these statistics there. So with 869 surgeries performed per 100,000 of the population, that will lead to the 260,700 SSIs in Ghana. And so assuming SSI rates of 11%, that will mean that will result in 30,532 avoidable SSIs with the intervention. That is, if you go by what we observe with the intervention in terms of the decline in SSI cases. And that, just opposing that with the ISSER value of the 3,451 US dollars, that will give us a total of 105,365,932 US dollars in cost savings. In my next slide, I'm projecting a summary and conclusion of the study. Now, we say that SSI mortality rates overall decreased by 33.3% post-intervention, while the SSI attributable LOS, outpatient visits and laboratory tests also decreased by 32.6%, and then 34.3% and 48% respectively. The SSI attributable patient cost of hospitalization also declined by 12.1% post-intervention, while the hospital cost associated with SSI also dropped by 19.1%. The intervention, I must say, led to an estimated incremental cost effectiveness ratio of 3,451 cost savings per SSI episode avoided, which is equivalent to $105,365,932 in societal cost savings annually for Ghana. The intervention was a simple but a dominant strategy that can be implemented in a resource-constrained setting in LMICs. And so hospitals that are already monitoring SSI cases could also look at our intervention, which is a 30-day surveillance strategy of SSI. And doing so, you are able to track, you are able to educate the staff also and raise awareness, and that will keep your SSI low. So at this point, I say I thank you for your audience, and I'm glad to participate in this study. Like I said before, the pre-intervention study is published in the Infection Prevention in Practice journal, which is an Elsevier journal, and the surveillance study is also published in the Journal of Hospital Infections, or available free of charge because it's published open access. You can access it. The neonatal sepsis study has also is being considered by Applied Health Economics, which is also an Elsevier journal. And this one is also being prepared for Health Economics journal for publication. And so I look forward for interactions from the audience and the general public. Thank you very much. I end my presentation here. Thank you.